Hello, welcome everyone. Good afternoon. This is the third of our series, As the End Nears. And today we're going to be talking with Dr. Christina Yeon about what it is to die of cancer. I want to first thank everyone who's been involved in this process in getting this series going. It's been such an honor to be able to meet folks virtually as we discuss these complex illnesses. And I really want to thank you, Dr. Yeon, for your time today and for sharing your expertise with us. Before we begin, I want to invite the audience that if you have questions throughout our time together today, please go ahead and insert them in the Q&A. You'll see that at the bottom of your Zoom screen. We will have time during our time together to actually go through some of your questions. We'll do our best to answer them as best as we can, and we appreciate your understanding and your flexibility with the Q Bank. So getting started, Dr. Yeon, would you share a little bit about yourself with us?
Thank you so much. It's an honor and a privilege to be here today. I really appreciate being able to spend this time with you. So my name is Christina Yeon, and I'm a medical oncologist at the City of Hope, which is located in Southern California. I immigrated to the US when I was 5 years old from Seoul, South Korea. I grew up in Riverside, California, which is about 80, 90 miles away from Los Angeles. And then I attended all of my higher education at UCLA, where I went to college, medical school, residency, and fellowship. My special interest is breast medical oncology, but I am board certified in general oncology as well as hematology. And I've been in practice since 2004, and I currently practice in the Pasadena area. And I am really lucky and blessed to be able to focus my practice on breast, which is my special training and interest. Thank you so much.
Thank you, Dr. Yeon. We appreciate you so much for sharing your time and your expertise with us today. My name is Susan Wolfowitz. I'm a palliative medicine doctor in Denver, Colorado, and I'm also one of 2 national medical directors for Compassion and Choices. So thanks everyone for joining with us today, for taking the time to learn about As the End Nears with metastatic cancer. Dr. Yeon, may we just start our conversation today by trying to understand the stages of cancer? What does that mean? How many are there?
Sure. Generally, there are 4 stages of cancer, 1, 2, 3, and 4. And the staging is dependent on the size of the primary cancer, 1 centimeter, 2 centimeters, so forth, as well as whether that cancer has spread to the nearby lymph nodes, which is a common area for cancers to spread. And lastly, if it has been spread to any other sites of the body, such as metastasis outside the primary area of where the cancer started. So this is referred to as the TNM staging, the tumor, node, and metastasis. And the TNM staging criteria for all different types of cancer is different. And based upon that, your doctor is able to give you a stage for your disease.
Thank you. And what do oncologists or cancer doctors mean when they say things like terminal or end stage?
Sure. When we talk about a terminal cancer, generally we're talking about someone whose cancer, unfortunately, is stage 4 and has spread to other parts of the body or other organs. And that is the term that we generally use when someone has stage 4 disease.
Okay. And would you say that all stage 4 cancers mean someone has terminal cancer?
I would say generally speaking, that is correct. However, there are several nuances to this. So there are some cancers, even though they are considered stage 4, they are potentially still a curable disease because of the ability for us to possibly offer like other treatments like bone marrow transplant, stem cell transplant. So things like lymphomas that are stage 4 are still technically considered a curable disease and are not necessarily terminal. Same thing with stage 4 testicular cancers, where we can offer stem cell transplant. So you need to discuss this with your doctor to get clarity on whether your disease is going to be a terminal disease or not, based upon the subtype that you have, even if you might be considered stage 4.
Okay. It sounds like you're saying that some types of stage 4 cancer can be downstaged. Is that correct? And can you help us understand what downstaged means?
Yeah, so this is a question I get often from my patients about, okay, I have stage 4 cancer, but if I, get chemotherapy and the chemo works well, can my stage go down? That is not, unfortunately, a possibility. So once you have stage 4 cancer, you're always going to be having stage 4 cancer. And that's what all of your doctor's records and notes and things will say. However, let's say somebody has a stage 4 lymphoma and has chemotherapy with a stem cell transplant, and they have no evidence of disease and go into remission. They can be considered in remission, but still technically have that stage 4 diagnosis. So downstaging is not a possibility, but still going into remission might be a possibility with a variety of treatment options.
That's hopeful. Thank you for that. Speaking of the treatment options, nowadays there are so many different opportunities, modalities, interventions. Would you be able to take some time and just kind of talk us through what your typical cancer treatments are?
So when we talk about treatment, I always talk to my patients about local therapy versus total body therapy. So local therapy is generally going to be focused on options such as surgery as well as radiation therapy, where we're literally just trying to remove the tumor from where it started, be it the lung, the colon, the breast, and whatnot. And then total body therapy is with regard to options such as chemotherapy, which are generally IV infusions, occasionally oral medications, as well as this new topic of immunotherapy, which is generally also IV infusions, and hormone therapy for some cancers that are sensitive to hormones, such as breast cancer and prostate cancer. So the surgery and radiation therapy are given by the surgical oncologists and the radiation oncologists, and the total body therapy, the hormone, chemotherapy, immunotherapy, that's under the realm of your medical oncologist.
Thank you. And I want to definitely get into the role of palliative care and how important palliative care can be in someone's cancer experience. But before we really get into the palliative care and the idea of that robust interdisciplinary team, I know a lot of patients who do receive what we call palliative chemotherapy or palliative radiation. And I think that sometimes there can be some confusion about how those terms differ from palliative medicine or palliative care. Could you help us understand those treatments relative to how they support a patient in their cancer experience?
Certainly. So when you are looking at palliative treatments, palliative means that we know that the treatments are not going to cure the patient of their cancer, but the goal is to help the patient, either decrease the burden of the disease. There's a question I see that somebody is asking about what is the definition of metastatic cancer? So generally, metastatic cancer equals stage 4 cancer, where it has spread from the primary organ where it started and has gone to other parts of the body. So when somebody has stage 4 metastatic disease, we're offering, palliative chemotherapy, sometimes even palliative surgery, palliative radiation, where we know this is not going to get rid of the cancer for the patient and cure them, but we still are offering that because we know it's going to help them with pain, help them with bleeding, help them with breathing, other ways that we know we can definitely make an impact on the patient's quality of life.
Thank you. And that's a perfect entry into really the role of palliative care in an individual's cancer journey.
So palliative care, thankfully, is a category of medicine that has evolved. So when I was in training as a fellow, I did my fellowship between 2001 and 2004. Palliative medicine wasn't even a thing. It wasn't even on the radar. That was not even a word that we used. But since then, it has, emerged as a specialty. And thankfully, the palliative medicine doctors are working hand in hand with the oncology physicians. So palliative medicine is focused on helping patients deal with the physical, the emotional, the spiritual, the side effects of the cancer itself, as well as the cancer treatments that are being offered. So the palliative physicians are working hand in hand with the cancer doctors to help manage the patient's disease and help the patient navigate their disease course to hopefully have the most smooth course possible in terms of pain control, nausea control, symptom management, as well as offering psychosocial support as well.
Yeah, thank you for sharing that. I've had a lot of experiences when patients have been referred to me as a palliative medicine doctor from their cancer doctor, from their oncologist, and the patient may have a stage 3 disease, and they come to see me and they're really hesitant and they're really scared because they think that because they're seeing palliative care, they must be dying. And so something I think that's really important to hear today is that palliative medicine comes alongside patients, comes alongside individuals as they're dealing with their complex illness, as they're dealing with their cancer. And particularly, I think with cancer, because the treatments for cancer can be so challenging, I think it's wonderful to have oncologists partner with palliative medicine doctors so that the individuals who have cancer can better tolerate these treatments, can actually heal better and actually face their cancer with more symptomatic support. And so once I work with patients and explain to them that, no, you're not dying. We're just here to help with your nausea, for example. And we build these relationships, it really becomes this wonderful partnership, I think, between oncology and palliative medicine to really support the whole person, the whole patient as they face cancer. With your experience, how often or at what point in someone's cancer experience do you encourage or refer to palliative medicine?
Certainly. So I generally tend to refer patients to palliative medicine pretty early on when someone's diagnosed with stage 4 metastatic cancer, because generally I know that the patient's going to need help from the palliative medicine doctors sooner than later, and so I want them to build that relationship and have that trust and that relationship with each other, so that the palliative medicine physician can help me co-manage the patient as we go on. And as you were mentioning, Susan, you definitely hit it on the head that I have some patients who are stage 2 and stage 3, not stage 4, but maybe they're getting combined concurrent chemo and radiation, or they're having something else going on where I know they're having a lot of side effects from the treatments that we're offering, and I'm going to need that extra help. And that patient's going to need that extra layer of support, another person and team that they can reach out to for questions and assistance, in addition to myself or the radiation oncology team and so forth. And so we definitely make that referral. And yes, I definitely tell the patient, I'm referring you to palliative care because I want them to help me with XYZ. It's not that I think you're going to die in the next month or so. This is not a hospice referral. It's a palliative care referral. And I try to explain that because definitely patients are extremely hesitant to make that appointment with the palliative care specialist, but I encourage them to do so. And once they do, the patients usually end up thanking me, saying, oh, thank you so much. It's so helpful. I didn't know that there were all these other options because I'm board certified in oncology, so I know the best, chemotherapy, immunotherapy, but I might not know all the greatest, pain meds or nausea meds that are out there, but someone like yourself would know that information.
And I love that partnership. I think it really is what the patient deserves, the person deserves, to be able to have that's multidimensional care offered in an otherwise really challenging time. Another thought that I'm curious, because you mentioned all these different, the different stages and then the different treatment options. And I can imagine for individuals who are facing these decisions, it can feel really overwhelming to know what to do, to treat or not treat, to do this type of therapy rather than that type of therapy. So how do you counsel your patients on their decision-making process?
So thankfully, I think the practice of medicine has changed, whereas 50, 60 years ago it was more kind of the physician saying to the patient, I recommend this and this is what we're going to do. But now we are more in a partnership with our patients. So I want my patients to feel like I am helping them and I'm guiding them and just offering them information so they can make their best informed choice. So when I have a patient and we're talking about treatment options, I basically let them know, okay, these are the options, A, B, C, or A and B, and these are the side effects of the options. These are the benefits. These are the risks. If we do A, then it could lead to this. If we do B, it could lead to this. What are the chances in terms of statistics and numbers? If I have that information about, what's the likelihood that this treatment will help you? And then, how is the treatment given? Is it once a week? And so you can't go on that long vacation that you want, or maybe it's once a month. So you could go on that long trip with your family that you were planning to do. And so then we just give the patient all the information that they hopefully need so that they can make an informed choice about whether they want to pursue that treatment or not. Is it right for them or not? Because every individual's case is different.
Yeah, I really appreciate it. It sounds like you are really taking into account the statistics, the evidence, the treatment options available for each individual, but also combining that with what's their lifestyle, what's their quality of life, how are these things going to impact or not their daily lives. And so I think that's something that I would love to really encourage our audience to do, is to try to get as much information that you can from your physicians and ask questions like, well, how is this going to impact me on a daily basis? How is this going to impact this plan I have for a trip? To make sure that whenever you're making a decision about your care, that you feel that you have the medical information that you need and you understand it in a way that's meaningful to you. And equally as important, how these decisions impact you as a person, as your quality of life. So I really encourage and I'm hoping to empower everyone today to feel as though they can have these types of conversations with their doctors. Kind of switching gears, I'm wondering, I know a lot of folks that come to me because they are been entered in a clinical trial, hoping that this clinical trial will help themselves, but also help other people. Would you be able to speak to us a bit about the role of clinical trials in an individual's cancer experience, and maybe offer some advice to our audience today about how they might approach an invitation to a clinical trial?
Absolutely. So a lot of patients who are getting treated for cancer may have questions about clinical trials, but unfortunately, only a minority of patients in this country actually ever enter into a clinical trial. I think the most recent statistics I've seen is less than 10%. But a clinical trial, bottom line, is nothing for you to be scared of. Don't automatically think, no, I don't want to do that. I don't want to be a guinea pig. I don't want to be, tested on, because that's certainly not the case. So a clinical trial is essentially a treatment option, and it could be a surgical clinical trial while we're testing two different options of surgery, or a radiation clinical trial, two different cocktails or duration of radiation treatment. And of course, for myself, the medical oncology world, we're offering clinical trial where we're looking at new chemotherapies, immunotherapies, hormone therapies, and so forth. Think about the fact that you are currently receiving standard of care medications for your disease, standard of care surgery, and so forth. That all became the standard of care because other people in the generations behind you enrolled on a clinical trial, so that we did the research and the studies to confirm that that was the best treatment options for patients. So a clinical trial does not mean that you have stage 4 metastatic disease and there are no other treatment options left. That is certainly not the case. There are clinical trials available for patients throughout all stages of cancer. I've enrolled patients with stage 1 disease on a clinical trial all the way up through stage 4. And the clinical trial is just looking at usually one treatment, which is the standard treatment that is currently the standard of care here in the US, versus another treatment, which is the clinical trial option. And so the doctors are offering you the clinical trial because they think it might help you, as well as, of course, help the scientific research endeavors and giving us more information for us to move the needle forward in terms of cancer treatment here. But please do not be afraid about a clinical trial. Ask questions. Why do you think this clinical trial is appropriate for me? If I'm not going to go on this clinical trial, doctor, then what would you recommend? What are the side effects? Are there any extra side effects on this clinical trial versus if I just went with standard treatment? Just get those questions answered so then you can make a decision. And a clinical trial is always going to have an informed consent form, which is written in layman's terminology. It's not written in medical mumbo jumbo, which most people, don't want to read. And then it's going to be something that clearly explains, you'll have blood draws, you'll have x-rays. This is how the treatment's going to be given. What are the side effects of the treatment? And then you get to decide if you want to pursue that clinical trial or not.
Yeah, so the choice is really still in the individual's ownership.
Absolutely. It's something that's being recommended as an option. It's not going to be the only option for the patient. They'll be given a choice.
Excellent. I've heard from some individuals over the years that while they're trying to decide about their cancer treatment or not, they worry about disappointing or frustrating their doctors, or disappointing or frustrating their families if they decide not to pursue treatment. And so how can you help our audience today and others feel empowered to make decisions that best honor their individual needs and their values?
I think this is such a good point that you bring up, Susan. Unfortunately, this is more common than I think sometimes even the physicians realize, that the patients are honestly scared to disappoint those around them. But what we have to focus on is this patient's cancer, this patient's journey, and this patient's choice, right? Whether or not they're going to do that surgery, go for that chemo, have that radiation, whatever side effects are going to happen, it's going to happen to that individual patient. And they're the ones that they're going to have to go through all of those side effects from the treatment and then figure out what's going to happen next. And so I usually always tell my patients, don't focus too much on what your spouse or your child or your sibling is saying. And certainly don't think about, oh, I'm going to disappoint Dr. Yeon if I don't go for this clinical trial that she's recommending. She's worked so hard. That's okay. There's going to be pros and cons to treatment. You have to take ownership of your own health as the patient and make your informed decision. And certainly you are not going to be disappointing your physicians if you don't, make whatever what you think is the quote unquote right choice that you think that they want you to make. Essentially, we're trying to empower our patients to say, this is the option. These are the side effects, risks and benefits, and please let me know what your choice is. And I always use the terminology. I tell the patient, the choice is yours. I will respect your decision. And then I even have some patients tell me that they're worried that if they don't take a treatment option, that I won't be their doctor anymore. And so I literally will manually actually say out loud, I will still be your doctor, regardless of what choice you make. I will still follow you. I will still help guide you through the next stage.
That's actually so caring. And I hear so much empathy in what you're saying. And I can only imagine how meaningful that is to the patients that you work with and their families to know that they have you as an advocate for their individual choice. So thank you for being that advocate for people.
Thank you. No, certainly. Especially for patients with stage 4 disease where it's metastatic, where we know it's palliative intent. So there's two intents to treatment. Usually we talk about, is this a curative intent where we're giving this patient all these treatments to hopefully cure them of the cancer so the cancer will never come back? Or is it palliative intent where the focus is not cure, but certainly the focus is going to be controlling disease, controlling symptoms, slowing down the disease process. People with stage 4 disease, I want my patients to know that I am there with them as a partner. We're working together. We're, walking down this road together, and I'm going to make recommendations, treatment, just basically pros and cons, explanations, recommendations, and the choice is ultimately theirs, but I'm not going to be abandoning them anytime on this road. So sometimes I literally tell my patients, as long as I don't move away and nothing happens to me, I'm still going to be here to help you navigate this journey.
Yeah. And I think that's what people deserve. So I'm just grateful that you do that for the patients that you care for. And I love that you really elevate their experience because you are the expert in their cancer and they are the expert in themselves. And making sure that that voice is really heard, I think is vital to anyone's experience.
Absolutely.
Kind of along these lines, how can an individual with cancer initiate the conversation with their physicians about wanting to stop cancer-directed care?
Sure. So whenever I have a patient with stage 4 cancer, I generally, and I'm trying to kind of outline how the treatment will look like, I usually will ask them, do you want to know your prognosis? Most of my patients do, others do not. But then I always tell them, treatment options. We're going to keep going with treatment until either I think we should stop because I don't think you can handle it anymore. You want to stop because you don't want to handle the side effects anymore and you don't think you can handle it anymore. Or there are really no good treatment options left because I, don't have anything that I think is going to be reasonably effective and helpful to you. And so I always, plant that seed in my patient's mind so that they know that they can tell me at any time if they want to stop. The fatigue is too much. The side effects, like one side effect is peripheral neuropathy. That's a very common side effect, unfortunately, of a lot of different chemotherapy drugs we offer to our patients. And so if at any time the patient wants to stop, I want that patient to feel comfortable to tell me that they don't want to do anymore, or they might want a break, hey, I want to be going on vacation for a month. I want to have a break for a month from this once a week chemotherapy, and then we can rediscuss whether I want to resume it after I get back. So you want to leave that door open and you want to make sure that your patient feels comfortable to bring that up with you. But certainly any patient should feel comfortable with their physician to, initiate that conversation. Because the physician is there to help you and you shouldn't feel, like you're going to disappoint them if you want to stop the chemotherapy.
I think for patients who don't have oncologists that are as open, I think, and as you are to these conversations, I hope that everyone on the call today or in our meeting today can really hear your words, even if it's not coming from their physicians, but hear that you are opening this invitation that at any point throughout their experience, if they need a break, if they want to stop cancer treatments altogether, that they have that right and they have that power to do so. And that even if their doctors aren't opening the door when they're initially diagnosed with something like a stage 4 disease, I hope that they hear your words as they're considering their options and processing their experience, because I think people really do have that right to be able to say, this is no longer serving me, or what my goals were before, my goals are now have shifted. And I want folks to feel as though they have that voice and they have that power to say that to their own medical team.
Absolutely. Agreed.
In this spirit of our topic today is as the end nears, I'd like to shift and look at the symptoms that an individual with cancer could expect, kind of general symptoms from a terminal cancer.
So generally, as the disease course is progressing and the patient's symptoms are building up, what I usually see for my patients is that their level of fatigue becomes higher. Their need for supportive care medications, the anti-nausea meds requirement, the pain medication requirement, more, frequent dosing, higher doses of pain medication. You might also have episodes where you're not so mentally clear as often. And so you might be a little bit more confused because of the side effects of the cancer, as well as side effects of the medication. Because if you're on higher and higher doses of opioid or narcotic medications for pain, that can actually cause mental confusion for some patients and somnolence as well. Their appetite goes down. Usually thirst goes down first and then appetite goes down later. And so because of that, they're losing weight and becoming even more fatigued. And generally the body is just kind of slowing down and shutting down. And that's the general natural course of the disease as the cancer is progressing.
And I think sometimes it can be hard for us as physicians and for the individuals with cancer to distinguish, are these symptoms and what I'm feeling because of the medicines that I'm taking, the cancer treatments, or the medicines that are treating the symptoms of the cancer treatments, or is it the cancer itself? And sometimes it's a combination of all three, and it's hard to really parse out what's causing someone to feel the way they're feeling or experience their body the way they are. But certainly cancer, particularly to me, is such a complex symptom cluster, because you have the treatments themselves that create symptoms and the disease itself that creates symptoms. And then we treat the symptoms with other medications that can then also cause more symptoms. And so if people on the call who are experiencing cancer do feel as though they're more tired, or they're having more pain, or maybe their appetite or their thirst has decreased, these are all things that we can see in the end stages of cancer. And so I think it's important to talk with your physicians, be very vocal about what your body is experiencing, to see what tweaks or changes can be made to see if there's better ways to really help you to ameliorate those symptoms.
Absolutely. And this is why it's so key to have someone like you, Susan, the palliative care specialist, help someone like me, the oncology doctor, and kind of work hand in hand to help with the patients. And also, I will say some of the patients who are on this call might be doing this already, but sometimes my patients don't necessarily tell me all the symptoms they're having, but guess who they will tell? They'll tell my chemo nurse downstairs when they're getting chemo the next day. And then my nurse comes up to me and says, "Hey, Dr. Yeon, do you know that your patient, Mrs. Smith, is having more pain and she forgot to tell you?" I said, "Oh, okay." So then we kind of move on to, deal with that. But feel free to tell anybody on your cancer team, be it the doctor, the nurse, the social worker, because that information will trickle its way up to your physician. And hopefully that will get taken care of quickly. But, because everyone on the team is going to work together. That's why we're the cancer team. And we all kind of, share information, and so that we can best take care of the patients.
Yeah, I think that team approach is so important, because the person isn't just that physical body, it's so many aspects. And I think having the team and having multiple disciplines involved in someone's care really can make sure that someone is getting a more robust, comprehensive experience.
Yes, correct.
And something that I don't necessarily hear from patients, but I have had many family members over the years ask, and is dying from cancer painful? And will my loved one suffer?
The answer to that is no, because we're going to be, usually by then you are hopefully enrolled on a hospice program with palliative and comfort care measures in place, where they are giving you the pain medications, the nausea medications, the other medications to control this, the oxygen tanks, the suction machines, anything that you need to make sure that you are comfortable. That's the whole goal of having palliative care specialists, hospice nurses, hospice experts involved in a patient's care at the end of life, because we want to make sure that there is no suffering, that there is minimal suffering, and that everyone's quality of life and the dignity of their life as a human being is at the highest possible level for as long as we can possibly maintain that.
I was thinking earlier, we talked about palliative medicine earlier in our conversation, and how palliative care for people with cancer can happen at any point in someone's cancer journey. So it could be stage 2, it could be a stage 3. You do not have to have terminal or end stage or metastatic cancer to benefit from the collaboration of palliative medicine. And I would say that for people that do have stage 4 cancer, that do have terminal cancer, metastatic disease, it can be so helpful to have palliative medicine on board, because palliative medicine can be such a natural bridge into hospice enrollment. And I think that making sure that folks understand that palliative medicine can kind of be this usher to say, hey, we've reached this point where our services are no longer serving you as well. And there's this other layer of support, this more intense level of supportive care that hospice can provide. And so making sure that folks do understand that that transition from palliative medicine or palliative care into hospice enrollment or hospice team can really be such an opportunity to really focus on someone's comfort, the quality of life, making sure that symptom management is optimized. So as you just said, Dr. Yeon, that someone's dignity can be maintained for as long as possible and that folks can feel as well as possible for as long as possible.
Absolutely. So earlier on in the journey, when someone's still on active treatment for stage 4 disease, I'm kind of taking the front seat, and the palliative care team is a little bit on the back burner, so to speak, but still working hand in hand. And then we switch places at the end of life, where the palliative care is taking a front row, seat, and I'm kind of backing off a little bit. So it's this transition, and it's basically a continuum on this journey.
Yeah, thank you. I love that transition continuum. It really is. Along these lines, we're talking about when folks have terminal stage 4 disease and their options are no longer for cancer treatment. There were very limited options, or maybe no options, or maybe the individual has just decided they no longer want to pursue cancer-directed care. What options do people have at the end of life for their dying process?
So I always encourage my patients to enroll on hospice. So hospice is a program where hopefully a lot of the people on this phone call, on this Zoom meeting, will know about this, where you have a terminal disease, be it cancer, end stage heart disease, end stage lung disease, or whatnot, where your physician has deemed that your survival and prognosis is usually going to be less than 6 months, and no more disease-directed therapy is being given. So you've stopped the chemo, no more radiation, and so forth. You enroll into a program, and generally it's a program where the team is coming to you at your home, or a home. Maybe it's your home, your friend's home, your loved one's home, and they're providing nurses, supportive care, pain medication, oxygen tanks, all of those things that you need to help maximize your quality of life and support you in the end stages of your life as the disease is progressing. In some states, including California, there's also the option where patients have asked me about the medical aid in dying medication, which is available to some, but not all patients. And there are certain criteria that have been established in each state about who was qualified to potentially participate in the medical aid in dying medication process. So those are the two kind of general options. But even if someone does end up pursuing ingesting the medical aid in dying medication, I definitely always recommend to be on a hospice program, because it just offers, like you said earlier, that extra layer of support. It is way more than just palliative care. It is way more than just home health nursing, because some of my patients ask, well, can't I just continue my home health? No. Hospice is, it's like a Mercedes-Benz versus home health is like a Honda. So you want to make sure you get that higher level of care, all that extra support that you deserve to have.
And I appreciate you mentioning the option that patients have where it's available to them in a state where it's available to offer the medical aid in dying medications that an individual can decide to self-ingest and can decide how to chart their own course at the end of their life and make their dying process meaningful to them. And I think that when people are facing stage 4 cancer, metastatic disease, and the terminal phases, I've had many patients exactly with that description approach me about medical aid in dying. And it's something that I always talk openly with our patients about, because it is an option here where we live in Colorado. But for folks who don't live in a state where medical aid in dying is accessible, another option that patients can consider is called VSED. So it's the voluntary stopping of eating and drinking. And it's when a person that has a terminal illness voluntarily decides to no longer eat or drink, and therefore allow themselves to hasten their death or to choose their dying experience and their own way. And so that's another option that patients do have, whether you live in a state or not, where medical aid in dying is accessible. That is another choice that people can make. And I would just echo what Dr. Yeon already said, which is that whichever option you choose, whether you choose to pursue the natural course of your illness, whether you choose to pursue the voluntary stopping of eating and drinking, or if you choose to pursue medical aid in dying, I think it's really important at all points in your experience that you do have that supportive hospice team involved. They're there for the what ifs, they're there for 2 a.m. when bad things happen and you don't want to call 911 because you don't want to go back to the hospital, you want to be able to stay at home. You can call that hospice team at 2 a.m. and they'll be able to support you and guide you and your loved ones through whatever crisis is happening. So I definitely say that whenever someone's facing whatever their end of life journey is, to make sure you have that robust and supportive hospice care team. So, yeah. Is there anything else, Dr. Yeon, that you would want folks in our series as the end nears to know about or think about as they face terminal cancer?
I think we've hit a lot of the highlights during our discussion today, but I think what I would say to kind of as a take-home message for our folks here on the call is that this is your life, your body. Patients should be able to make their own decisions, informed decisions. So ask questions. If you're not sure about treatment options and what the side effects are, get the answers that you need to ensure that you feel like you are comfortable making an informed choice for yourself about whether you do or do not want to go down that road for treatment. You also want to make sure that you feel comfortable with your physicians because they are your partners on this journey. They're not just like up here and the patients are down here and the doctors are talking and saying, okay, these are the decisions being made. No, it's like, hand side by side, right? We're driving together in this car and we're going down this road together. And so speak up, ask questions, be comfortable. Also, if you feel like you need to get a second opinion, guess what? Ask. And if your doctor is offended or upset that you're asking for a second opinion, then maybe it's time to find a new doctor. Honestly, a doctor should never feel offended that their patient is asking for a second opinion. I encourage my patients to get a second opinion, maximally maybe a third opinion. After that, patients just start getting confused when you have more than 3 opinions. So ask, get information, and make sure that you are advocating for yourself because this is your life and your health.
Thank you. That was so beautifully said. And again, for folks out there who maybe don't have an amazing physician or feeling as connected to their physician as I feel with Dr. Yeon, please hear her words and know that even if your medical team isn't quite what you hope it is, I want you to take these words and feel empowered so that you have that voice in your life and your entire experience. So thank you so much. If it's okay with you, I'd love to move on to our question and answers, our questions. And hopefully we have some answers for folks.
Sure.
Excellent.
Well, this is Dr. Corey Carroll. Thank you to the questions have been coming in exquisitely fast and furious, but I think something that I'll just kind of outline that a lot of folks weighed in that they don't feel that they have the support they need. And we certainly know there's some disequity and lack of access. So what would be your, and there was a question on cost for hospice. There was also a question on pulse form. So I would just ask the two of you in a situation, and Susan mentioned, if you're not comfortable with your doctor, try to move on. But when you have limited resources, I know this is a tough one, but what suggestions would you have for patients who are looking for the kind of doctors you two are portraying today? And are there advanced directives that can help with that process prior to? Maybe that'd be another question.
So I'll tackle the limited resources part. So once the pandemic hit, one of the benefits of COVID-19 that I've seen is the explosion in telemedicine and telehealth. And so with that, we have been able to really increase our ability to do televideo visits, even telephone visits. And prior to COVID, physicians were hesitant to do that because, unfortunately, mostly surrounding reimbursement concerns. So right now, I would say if someone is in an area where there's limited resources and maybe a second opinion doctor is many, many hours away by car, I would look into possibly having a televideo new appointment as a second opinion consult, because a lot of times a physician can review your medical record, look at your pathology, look at your imaging study reports, and make some recommendations. They don't necessarily need to physically have you in the room with them to still make a medical recommendation.
I absolutely appreciate the question about the POLST form and about advanced directives across the board. For folks who don't know, the POLST or the MOST form is a physician's order signed by a provider, medical provider, and signed by the patient as a directive to anyone involved in that person's care, a true medical order that outlines the patient's wishes. So it's similar to a living will in that it actually articulates the patient's wishes, but it's distinct from a living will because it truly is a medical order meant to be adhered to, meant to be followed by anyone on the patient's medical team, whether it's EMS and the hospital system. So the POLST or the MOST form is really intended to be an elevation of the patient's autonomy, of the patient's voice, if there's ever a time when the patient's unable to speak for themselves. Ideally, this form would be honored by the medical team and by the patient's loved ones. We've all heard of terrible cases where that hasn't happened, but I would still say I would encourage everyone to complete a POLST or a MOST form after having a meaningful conversation with your individual care provider, your physician, someone on your care team, ideally someone with medical expertise who can really help you understand the complexity of the choices that you face and how they apply to your unique situation. I do think that these forms absolutely require an engaged conversation between you and a physician. If someone is feeling as though they're not being heard by their doctors, I am so sorry. I just want to name that and how scary that would be and how vulnerable that would be and how frustrating that would be. And I would say, keep speaking up, keep asking questions. If you're not getting the questions answered that you need from your physician, especially with a cancer team, oftentimes there is a social worker involved. And so really trying to engage the support of the social worker too, to just seek another advocate. I think social workers and nurses are phenomenal patient advocates. So if you're not feeling heard by your physician, again, I apologize. And I would say be vocal with the other members of your care team to see if they can help elevate your voice.
Yes, and a side note there, I just wanted to say that for the POLST form, I actually have POLST forms in both English and Spanish in my, I practice in California, in all of my exam rooms at all times. And so I will literally sometimes just hand it to the patient and say, let's discuss this at our next visit, but I just want you to look it over, see all the different check boxes that are available, and then we can discuss. And then once it's hopefully filled out, the patient keeps the original, I get a copy, so that if anything ever happens, they have the original and they have it like, stuck on their refrigerator door or somewhere so the whole family can see where it is.
Hi, this is Mitz Tamita. We had some questions about terminal sedation. Could either one of you explain what that is and its role?
So I'll let Dr. Wilhoit take this one.
Yeah, thank you for that question. Palliative sedation, or I think you said terminal sedation, but I'm hearing palliative sedation as another option at someone's end of life. What I would say to people is that palliative sedation is when someone has symptoms relative to their end of life experience, to their dying experience, to their dying process, and the symptoms are not responding to the typical aggressive symptom measures that we can offer. So an example would be someone who maybe has a very high tolerance of opioids, because maybe they've used opioids historically and their body has now built up this huge tolerance to opioids, and they're having terrible pain from maybe a bone crisis or cancer crisis of some kind, and they're having horrible pain that despite unbelievable doses of strong, powerful opioids, their body isn't responding. And so they're still suffering from this terrible pain. And so what we'll need to do in situations like that, if the patient is truly saying, I can't take this anymore, this pain is intolerable, this pain is unbearable, I am suffering, I need you to do something more, we have the option of what we call palliative sedation, meaning that we knowingly are giving someone medications that will cause them to be sedated to the point of unconsciousness and will cause their death, because the doses of the medicines that we're giving are going to cause someone to die. These are terminal dosing, but we're not doing it to kill the person. We're not doing it to end the person's life. We're doing it to aggressively manage their intolerable suffering. We think of it as refractory symptom management. So when someone's symptoms are not responding to the typical aggressive pain medications that we can offer, we do have this other option of offering palliative sedation, in which we knowingly are giving doses of medications that we expect to kill the person. We expect the person to die, but the intention of offering these medications is not to cause death, but rather to alleviate someone's suffering. And so this would be something that someone doesn't go to their doctor and say, hey, I want terminal sedation. So that's not something that a patient can just go in and ask as an option. It's really a response by the medical team to refractory symptom management. And so I don't really often include it in how I think about a patient's end-of-life options. Like I think of the voluntary stopping of eating and drinking, medical aid in dying in the jurisdictions where it's allowed, et cetera, because it's really driven by the clinical experience of that individual.
Thank you. I'm just going to put a quick plug in for compassionate choice. I've heard both of you say that conversations, not only with your doctor, but your family, are important, and certainly doing this sooner than later. At Compassionate Choices, there is a lot of effort on end-of-life decision-making and a toolkit that can help in that. A question that came up was alternative treatments at the end of life. Not that we want to go too deep into it. A physician asked about some of the psilocybin and MDMA, some of the things that could help. And there were questions about I know, Dr. Yeon, you talked about no pain at death, but there's some folks that were really worried and certainly intractable pain. So, and I apologize to throw a lot of things out at you, but I think also the doula was mentioned as an opportunity to help at the end of life. So early discussions, but what about alternative treatments and providers at the end of life to help with the suffering and pain?
I would say generally, most of my patients who have opted to pursue alternative treatments do so earlier than at the very, very end of life. Usually, maybe at the first time they're diagnosed with stage 4, or maybe after the first round of chemotherapy for stage 4 is maybe no longer effective. But for at the very end of life, my patients generally are not seeking alternative care, as far as my understanding is. However, if there truly are no other options available, and or the patient has opted to stop treatment because of intolerable side effects, I certainly do not want them to stop seeing me, right? I'm going to offer my patient, okay, if you're going to pursue alternative medications with another provider, or maybe going to another country to seek these treatments, just know that I'm always here, I'm always available, keep me updated on what's happening. So I want them to know that I'm still part of their team and I'm still here to help.
Yeah, I love that advocacy again. And I'll address just a little bit about ideas of psilocybin or MDMA or ketamine at the end of life. And the thinking behind some of this is really to alleviate someone's maybe existential suffering, if you will. So if someone is experiencing a fear of death, or they're having concerns about maybe something earlier in their life that they need to look at more deeply, there are ideas out there that things like the psychedelics, psilocybin, ketamine, MDMA, can be helpful in someone's processing of their dying experience. And there's certainly been reports of patients really feeling after having one of these treatments, having a sense of relief, a sense of ease, a sense of acceptance about their dying process. It really can do a lot. The psychedelic assisted therapies can be really helpful in addressing and facing the fears that some people may experience at the end of life.
We've had some questions regarding medical aid in dying. If that's not allowed in your state, and you go to another state, how do you do that?
Yeah, so as of right now, Vermont has officially removed the residency requirement for individuals within the state of Vermont who receive medical aid in dying medications. There is a website that people can access that's from Vermont that actually details how patients who are not residents of Vermont can access the Vermont end-of-life option and the medical aid in dying medications. Another state, Oregon, has no longer, it's not enforcing their residency requirement. And so that's another state where patients may choose to move because that residency requirement that most other jurisdictions have for medical aid in dying access is not enforced. And so it's really a matter of the patient physically being in that state. But for many people, obviously, if you're in a terminal condition, it can be incredibly hard to actually be able to move yourself, get your physical body to that state to be able to access the medications and access, the actual process, the rigorous process that an individual has to go through in order to be able to be eligible to receive those medications. So I don't have a straightforward answer for you other than that, yes, Vermont does now have, they've gotten rid of the residency requirement, and yes, Oregon no longer enforces their residency requirement. In both states, you can access through, I think it's through their end-of-life options networks in individual states, will be able to help patients understand the process to go about doing that.
Right, Susan, there was the website you mentioned. I put it in one of the questions, but it's patientchoices.org. And if you just Google Patient Choices Vermont, you should come to that website. And it's nice because it does detail. It's not easy to do, but it is doable. And hopefully we'll see not only other states allow medical aid in dying, but also drop the residency. There was a question about, how the religious organizations can sometimes get in the way of the decision making, certainly the end of life, but also some concerns about hospice and palliative care. Would you try to deal with that question?
I can try to tackle that. I'll do that. I'll try to do this in about 1 minute before we all say goodbye. Yes, absolutely. So individual institutions are able to create their own guidelines, their own criteria, their own rules about what they are willing and not willing to do and what they're willing or not willing to allow their staff to participate in. So it's really important. I mean, I think the truth is many people don't have a menu to choose from. They don't get to just go to whichever hospital they want or be involved in whatever healthcare system that they want. It's oftentimes a matter of, this is where I go because this is the only place I can go. And oftentimes those institutions have very limited options for patients at the end of life. So I want to acknowledge that for most people in the country, they don't have a lot of options to where they can receive their care because of just the sheer geography and the sheer limitations of what an institution can offer. And for those who do live in a place where you maybe have different options, I would absolutely encourage people to really try to have frank conversations with those healthcare institutions to understand what their guidelines are, what they are willing to do and not do to support an individual's choice, regardless of what those choices are. So I just want to acknowledge that it is something that people face. Even if there are laws that protect people, the institutions are still so powerful that really they get to decide how they care for people. We are out of time now. So Dr. Yeon, I want to thank you so much for being such an advocate for patients, for really giving people, I think, the language and the encouragement today that you did about what it is to die of metastatic cancer and to understand that as the end nears, their voice matters and their experience matters and their autonomy matters. So I hope for those of you on the call that don't necessarily have a doctor like Dr. Yeon, that you can hear her voice and hold on to her words and take it with you as you and your loved ones experience your cancer. I also really want to thank everyone at Compassion and Choices. There's been an incredible group of folks that have put these As the End Near series together. I'm so honored to be a part of it. And I'm so honored to be a part of such a dedicated group of individuals. And of course, with Compassion and Choices, none of this would be possible without our incredible donors. Your generosity makes this information available to people. Your generosity allows us to meet with experts like Dr. Yeon and to learn how we can empower ourselves in our own end-of-life process. So thank you so much to our donors for supporting Compassion and Choices. And thank you so much to Dr. Yeon for your time today. I want to offer everyone looking forward to June. In June, we will have our 4th series for As the End Nears, and we'll be talking about ALS and other neurodegenerative disorders. I'm really looking forward to that conversation. And again, thank you all so much for taking the time and for speaking up and knowing that your voice matters. Thank you.
Thank you, Dr. Yeon.